Thank you, Dr. K. Let me get my other panelists to come up here, and we've got a lot of questions. Try to get through as many as we can. Well, Jonathan, here's an easy one for you. What's with the Goofy 4 initial designation after the drug, and they don't have that in Europe, where they go by the trade name?
Right. So in the United States, I tried to avoid using brand names as much as possible. So I think for CME purposes, we have to have those 4-letter designations. But essentially, the 4-letter designation is to be able to distinguish multiple different versions of a biopharmaceutical, since the biopharmaceuticals are not identical. A generic small molecule, the active ingredient is identical to that of the reference product, whereas a biosimilar is highly similar but not identical. So it's not just for the biosimilars. When the biosimilars came out, these 4-letter suffixes were introduced, but if you watch TV and you see the new biopharmaceuticals, all biopharmaceuticals that are now approved, upon initial approval, get a 4-letter suffix as well.
Is that a 4-letter word?
Well, it was a 4-letter word for the first one, which was a Sandoz product, filgrastim SNDZ, but subsequently the FDA said that these had to be a 4-letter suffix devoid of meaning. So I don't think you're going to see a 4-letter suffix that you're thinking about.
A lot of questions on methotrexate. Joel, what's your creatinine cutoff for prescribing methotrexate, especially in a patient with gouts who have CKD? So maybe just what about GFR and methotrexate use? Your guidance.
Yeah, I don't know that I have an absolute cutoff. You have to be very careful. You can get into trouble if you're seeing a patient with so-called CKD. Let's say they have a creatinine of 1.2. What's their baseline? 120-pound female, maybe their baseline is 0.6. Whereas, a 240-pound guy, maybe his baseline is 1.3. So I don't have an absolute cutoff. It depends on the patient, the age, comorbidities, hypertension, etc. And I think GFR is important. I would probably not give methotrexate to anyone with a GFR below 40 at all.
Okay. One for Dr. Pope. RA patient in remission on methotrexate and a biologic. If weaning, ACR says wean methotrexate, EULAR says wean the biologic. So one of those has got to be a myth.
Right. They could both be a myth, though, because it depends. So EULAR did, when they updated, they did say wean one or the other, because they did do a systematic review in that Tamara trial. There was, I forget what it was called, but a trial of weaning CSD-MARD versus weaning the biological, same outcome. So the patient usually says, why don't you get rid of the drug that didn't work as opposed to the drug that costs more, right? So I would say it really depends. You could also do something, don't wean to discontinue. Both groups are very sure on that if you stop drugs, they usually stop working. Funny that. But basically, if you lower the dose of the biological, in many people you can get away with it. We just don't want to get anti-drug antibodies. But you can certainly consider not weaning anything or chipping away at one or the other, but not stopping the effective agent.
Okay. The microphone right here.
This is for the panel. Methotrexate raises homocysteine levels. Homocysteine levels can develop into endothelial dysfunction, which can lead to increased cardiovascular disease. Will folate supplementation help with that? And is there any advantage to using methylfolate over regular folate? Thank you.
That's an excellent question. Hyperhomocystinemia has been feared with use of methotrexate. However, when it was studied, the mean level increased from 13 to about 17, if memory serves. Toxicity from hyperhomocystinemia really only starts at about 30. So, although methotrexate inhibits MTHFR, which is the enzyme responsible for creating the conversion of homocysteine to methionine, when it's been studied, hyperhomocystinemia doesn't seem to be an issue with methotrexate.
And clinically, certainly in RA, other IA, not in primary prevention of people without inflammatory arthritis, but methotrexate does decrease cardiovascular events. So the hyperhomocystinemia story is, as Joel just said, it's true in a minutia kind of way, but it's not clinically relevant. It's out of fashion anyway right now, other than in lupus. Hyperhomocystinemia is not a big cardiovascular risk.
I think the reason, you're right, methotrexate decreases CVD, and I think the reason is why Paul Ridker got $50 million to study methotrexate prospectively to decrease cardiovascular events in 17,000 patients. The study was published in the New England Journal. It was stopped prematurely. They did not achieve their outcome, but if you ask Ridker and others, it's a methotrexate diminishes inflammation, and CVD is not all LDL. It's a lot of inflammation, too.
All right, Jonathan, my patients are already reading about biosimilars and having reservations on using them. How do you approach this?
I tell them that an FDA-approved biosimilar has been compared extensively in multiple different dimensions to its reference product, more recently than the reference product was compared to its original versions when it was first released. So that at least now we have recent data that the biosimilar is essentially equivalent and might have some safety benefits. In Nijmegen in the Netherlands, they did a study where subjects were educated by a nurse or a pharmacist for 2 hours about biosimilars, and they found that compliance with biosimilars was much better with education. So educating a patient, and in that case, it was a etanercept biosimilar, and they educated the patient that the risk of injection site reactions was lower and the efficacy was similar, and there would be a financial savings to the country. So if you educate your patient that there might be a safety advantage, if there is one, and that there's certainly no loss of efficacy, that should help to convince a patient that the biosimilar is acceptable.
So you'd give it to your mother-in-law. What about your mom?
I'd give it to my mother if she was still alive.
All right, up here, Dr. Rudeman.
This is for John. You're deeper in the weeds of the FDA guidance on biosimilars than probably anybody else here. So I'm curious, a couple of years ago, there was some noise about the CTP13, the one you showed us, trying to get a sub-Q version approved as a biosimilar. How was that even possible, or was it, and where they were just misreading the
Well, it's not yet approved in the United States. So Celltrion it was actually Pfizer and Celltrion that got CTP13 approved as an intravenous drug. Once a biosimilar is approved, it becomes an approved biopharmaceutical by itself. So it's infliximab DYYB. You can then approach the regulators to go for a different route of administration of an approved biopharmaceutical if you do appropriate studies comparing the pharmacokinetics with the different routes of administration. So that's how they're approaching it. They've done studies comparing the subcutaneous route of administration to the intravenous route of administration.
Got it.
Okay, Joel, there's questions about patients with hepatic fibrosis or non-alcoholic fatty liver with normal LFTs. What about using methotrexate in those patients?
Great question. If the AST is normal, you could use it. If they have established fibrosis, either by a biopsy or a scan, I would not use it. But in the absence of clinically relevant significant NASH without fibrosis, I think you can use it. Watch the AST.
Yeah, Joel, what amount of fibrosis? Because if you look on FibroScan, you'll find more fibrosis than you think you're going to find. So what degree of fibrosis would you say, whoa, we got to back off?
That's a great question. So the renix system is a continuum from normal to fatty liver to fibrosis seen only with a trichrome stain to full fibrosis to cirrhosis. So if you use a FibroScan, I think you're going to see a horse that's left the barn. And so I am not a big fan of the FibroScan. If you have fibrosis in a patient on methotrexate, I'm not sure that that's reversible. It depends upon the extent of the fibrosis. So I think you have to be very careful.
And we're seeing tons of NASH anyway. I mean, the high BMI, the hyperlipidemia, the glucose intolerance, they're like a metabolic wreck. So a lot of times the methotrexate gets blamed, and do you think it's an innocent bystander in those steatohepatosis people that go on to fibrosis, or it's a cause?
It probably contributes. I mean, NASH, as you say, is epidemic. So if you have NASH and you're on methotrexate, how do you assign guilt? And the answer is, I don't know. There's some combination.
Jonathan, you touched on cost. A lot of questions about cost. Is it going to be cheaper? Is it going to be cheaper for Medicare patients? How do you pick among biosimilars, whichever is more affordable? And I guess maybe one kind of that talks about all of that is, at the end of the day, what's the point of biosimilars if the cost to the patient is about the same?
So the answer to the last part of the question is that the introduction of biosimilars, as you saw from the graph that I created for average sales price, has decreased the cost of all biopharmaceuticals of that reference product. So the introduction of market competition has reduced the cost of reference infliximab, of Remicade, by about 50%. If the biosimilars weren't there, there would be no impetus to reduce the cost. As you see with adalimumab, adalimumab's gone up to $80,000 a year, according to the New York Times, as the list price. So the introduction of biosimilars has introduced market competition, which has driven down the cost of the biopharmaceuticals. It may be that the reference product turns out to be the least expensive. In 2018, in Sweden, where there's a tender process where each product goes up for bid, AbbVie introduced their bid at an 80% reduction over their previous year's price and beat out all the adalimumab biosimilars and became the only adalimumab available in Sweden for that coming year. They could afford to do that because Sweden has a population of only 4 to 5 million people. Whether that could happen in the rest of the world, it's unclear. But it's better to make some money from a product that you've developed and marketed for 20 years than to make no money from that product since you've already developed it. In terms of the earlier question, if the biosimilars are not able to gain market traction and the biosimilar manufacturers are not able to survive, then the brake on price increases or the impetus for price reduction on the biopharmaceuticals is going to go away. In terms of how the patient benefits, it's all up to the PBMs. I didn't show a slide about how PBMs operate, but they get a small percentage, maybe 2 or 4% of the average of the list price of a drug as an administrative fee, and then they get discounts and rebates back from the manufacturer, and they don't give all of the discounts and rebates back to the insurance provider. So that's how they make their profits, and they make billions of dollars of profits, and that's why they do prior authorization, because it's like a frequent flyer program. The more people they can get on one drug, the bigger the discount and rebate they can get, the more money they can make. So the whole reason for prior authorization is not for the medical benefit of the patient, but it's so that they can get more profits. So it's up to the PBMs as to choose which product's going to be available. With infusible biosimilars, which is what we've had up until now with infliximab and rituximab, it's up to the institution in terms of the contract that they can get for the product. So at our institution, we've had biosimilar infliximab and biosimilar rituximab because their acquisition cost is lower and the institution is able to get them at a more affordable price for our patients in our institution. So it's such a complex and opaque area that I can't really clarify it anymore.
And your university gave you a raise, of course. on the money, based on the money they
Right.
saved.
You need
Let's
your base salary.
ask Dr. Pope. You guys are ahead of us a bit. What's your perspective on the things we've been talking about with the biosimilars?
Right, so a couple things, and this is not unique to Canada. I think it would be the same idea here, and certainly was in Europe, that the patient, number one value is the patient should not be disenfranchised. So we had a lot of co-payments paid for by the innovator, the originator company, and as biosimilars came, if the patient says, but it's cheaper on the system, but I have to pay more, then that's actually unfair. So all these subsequent entry biosimilar drugs have had to basically take up paying the copay. We do have some people with an annual max or a lifetime max, and so that is better for them to have a drug that costs less. But the main thing that I think is really important for justice and for treating our current but our future patients is that the market, every time something enters the market, at least in rheumatology, I don't know about all the other areas, the market actually still expands. So although there's a retraction of money that you were showing over time because of less cost, not that it's a one-to-one ratio, the market expanded in Europe with more things being covered. As a for instance, the market has expanded for getting coverage and getting more people on drug in Canada for our healthcare is a provincial thing. So there's some provinces that have been doing this for about 7 years. And all the biosimilars are not going to necessarily survive in all areas. It might be if you have a big HMO that only, biosimilar number 8 of adalimumab will survive. And in, New York, you're going to have a different biosimilar maybe being the top one. Because there's so many, it's unbelievable to think that we have, I think, 9 adalimumabs right now. We have 5 rituximabs. We just still only have 2 etanercept biosimilars. But every other day, it sounds like another one's coming.
Joel,
if I could just comment on that. In the United States, the co-payment forgiveness cards are great for patients, but a Medicare patient can't use them, or at least in Massachusetts. So Medicare patients oftentimes have to pay a 20% co-payment. So for them, the lower the price of the drug, the less their co-payment, which can be huge. It's, again, a complex situation.
Joe, this question still comes up all these years. Does methotrexate worsen ILD in RA patients?
I don't know that it will worsen it. I would definitely, we discovered that when we did the case control epidemiologic study, that ILD was indeed a risk factor for subsequent methotrexate lung. Does it worsen ILD? I wouldn't want to do this study. I wouldn't want to use it. I would not want to do this study.
The onset of RA is less on methotrexate users by multiple registries, Brazil, Europe, et cetera. But there's channeling bias. If someone had really bad ILD, maybe you're not going to prescribe methotrexate. On the other hand, there's channeling bias that the worst patients in general get methotrexate as opposed to older studies where maybe they got sulfasalazine if you were in Europe. So certainly in the studies of use, of use of methotrexate in RA versus not use, propensity scored matching for what it's worth, less incidence of RA, but if less incidence of RA ILD, but if someone's on methotrexate and gets ILD, you could say they failed that, I'm going to have to treat their disease more effectively, because we have to think of treating the lung, but treating overall disease activity is a risk. I think we'd agree with that.
I agree.
Yeah.
I think it's what Joel said about checking a chest x-ray before you start it so that you know what had existed before.
Or don't look.
Jonathan, a question to get into the idea of the nocebo, which you sort of touched on, but maybe you could expand on. Patients on biosimilars such as infliximab or rituximab think it doesn't work as well as the original one they received prior.
So I left out, in the interest of time, this discussion of the nocebo effect. The nocebo effect is the opposite of the placebo effect. It's the idea that negative symptoms are caused by a chemical that's given to a patient. It occurs in about 25% of individuals, and it can account for the adverse effects of a medication that aren't due to its mechanism of action. In a study that looked in Nijmegen in the Netherlands, their initial study looked at 6-month survival on infliximab biosimilar compared to a historical cohort, and there was about a 25% drop-off on the biosimilar at the end of 6 months, but there was no change in disease activity measures for rheumatoid arthritis, psoriatic arthritis, or axial spondyloarthritis. When they looked at the components of the DAS28, there was a worsening of the patient global and a worsening of the tender joint count, but not of the swollen joint count or the assessor global. So it tends to be the subjective components of the outcome measure suggesting that nocebo effect is operating in discontinuation of a biosimilar. In their follow-up study where they educated patients, the survival was 97% on etanercept biosimilar, so they were able to eradicate most of the nocebo effect with education.
Pertinent to our last question, somebody wrote in to remind us that the current RA management ACR guidelines mention conditionally continuing methotrexate if stable lung parenchymal disease. I think that they did weigh in on that, which I think is useful and goes with the data from the registries. What about methotrexate polyglutamate levels? You mentioned those, Joel. You can obtain those as a test. Should we be doing them? We're not doing enough, or what value do they have?
Yeah, excellent question. I think there's pretty good data that efficacy of methotrexate is indeed associated with attaining an RBC, methotrexate polyglutamate level of Thierry Derview and I looked at this, of 60 nanomolar. And we thought that was pretty good science until some other investigators from New Zealand said, well, we can achieve a therapeutic level at 30 nanomolar. And I remember discussing it with my co-investigator, Dr. Derview. We didn't know what to make of their methodology and their approach. So I think where I would use a methotrexate polyglutamate level, it's RBC polyglutamate, is your patient who tells you they're taking methotrexate, and you measure the level and it's there's nothing there. So it's kind of a truth serum for, well, George or Gertrude, you're really not taking this drug. As far as monitoring efficacy, I think there's some value. We need some further studies.
So pretty soon we won't need that, right? Our Apple Watches will rat you out if you haven't taken your methotrexate. It'll report right to Dr. K there that Mrs. Gertrude is not taking her methotrexate as she says she's not. So there's a folic acid or not. You discussed this, so maybe we'll ask the panel. Do you use folic acid every single person? Do you not use folic acid? You mentioned the cost of folinic acid. Do you skip the day of methotrexate administration?
So I start everybody on folic acid 1 milligram orally daily. When I start methotrexate, I tell them to take it every day, not skip the day that they're taking methotrexate. If they start to develop nuisance side effects of methotrexate, I'll put them on folinic acid. Where I did my fellowship, I was told to start them on 1 milligram of folinic acid per milligram of methotrexate, but I've learned from Joel that I only need to give them 5 milligrams of folinic acid weekly. I tell them to take that about 12 hours after the methotrexate dose. Again, that was because of where I trained in rheumatology, and the methotrexate expert there told us to do it that way.
Janet?
So I think the easy answer is who knows. So the trainees will say, oh, you know, Dr. Pope, you have this patient, they're not on folic acid. And I go, yeah, but I think they're taking it, they're in remission. Their MCV is a little bit high maybe, there's no cytopenias, no side effects, who cares? But childbearing women and the elderly, because I think the elderly are at risk, I think they have less, in my opinion, less bone marrow reserve. Their GFR is often falsely looking better. If they look frail, you just know that they might run into problems. But because I do use a lot of triple therapy, so I'm giving dihydrofolate reductase problems by both sulfasalazine and methotrexate, I certainly don't mind them taking it. I usually just prescribe 5 milligrams once a week. I don't care about the day. But I used to prescribe, when I trained, 5 milligrams 5 or 6 days a week. And there's trials of anything and everything. 1 milligram a day, 5 milligrams every day, folinic acid, 5 milligrams, 10 milligrams. But there was a study looking at folic acid 5 milligrams daily, not in RA, but in men, and they were looking, because they were actually looking at some other, I think it was vitamin A or something. They were looking at some other vitamin, but they wanted to do a factorial and then get 2 for the price of 1. And there was more prostate cancer on folic acid 5 milligrams daily in older men than on the placebo folic acid, and that sort of had me maybe back off somewhat. But in general, I do prescribe it, but I actually don't care if they take it or not, and I'm probably wrong.
All right, Joe, I think you already told us, but quick summary, final word?
Yeah, Sarah Morgan at University of Alabama studied serum and RBC folate in relationship to reported toxicity in a very large number of patients. This was published at A&R. And there was a very strong inverse relationship between serum concentrations, serum and RBC folate, and toxicity. Lower the folate, the greater toxicity, and vice versa. I think I'm probably one of the few people in the room who remember when we first started using methotrexate, we didn't use folate. And it was a train wreck.
Okay.
Until
So
we use
you're a user. Okay. All right. Thanks to the panel. We're going to switch.